Imagine a world where the success of orthopedic surgery isn't just measured by a perfectly healed bone, but by how fairly that care was distributed and how holistically the patient was treated, even how sustainably the procedure was performed. Sounds like quite a lot to consider, doesn't it? Well, today we're taking a deep dive into that very world. The orthopedic landscape, as we know it, is undergoing a profound transformation. It's really not solely the realm of bone setting and joint repair anymore. It's expanding, influencing every corner of modern healthcare, and facing these complex challenges from societal demands, intricate patient needs, and yes, critical environmental pressures. And to help us navigate these significant shifts and explore what it truly means to be an orthopedic professional in this evolving era, we are incredibly fortunate to have Professor Mo Imam with us.
It's genuinely a pleasure to be here. This is an absolutely crucial conversation for our field, I think, touching on aspects that profoundly shape our practice day to day.
Our mission today for you, our dedicated listener, is to really unpack these transformations. We want to offer you practical insights into how orthopedic professionals like yourself can embrace a more holistic, equitable, and sustainable approach, ultimately enhancing patient care and shaping the future of our vital specialty. So let's get started. Professor Imam, let's begin with a reality that, well, often sits uncomfortably with us in healthcare. Rationing. We all strive to provide the best possible care, yet resources are inherently finite. How does this principle of rationing manifest itself within orthopedic practice, particularly in the urgent realm of trauma?
That's a vital place to start. Rationing, at its core, it's the necessary restriction of access to valuable or potentially useful health services, simply because of limitations. And it's not just about financial constraints, which is often the first thing people think of, is it? We're talking about the finite availability of skilled medical staff, highly specialized equipment, and crucially, operating theater time. These resources simply don't exist in unlimited supply. So in the face of, well, overwhelming demand, strict time limits, scarcity, and clinical urgency, decisions about who gets what, when, and how, they become unavoidable for the overall well-being of society, really.
And we've seen this play out in stark, undeniable terms quite recently, haven't we? The pandemic really brought it home.
Absolutely. The COVID-19 pandemic, for instance, dramatically highlighted these realities. During those early stages, many hospitals were forced to postpone or cancel a vast number of elective orthopedic surgeries. Now, this wasn't a choice made lightly, of course. It was to conserve resources, ICU beds, ventilators, and to reduce the risk of viral transmission. The consequence, however, was significant delays in care for countless patients with musculoskeletal conditions, even when those procedures were vital for their long-term quality of life and functional independence. But even outside such crises, the projected rise in demand for orthopedic surgeries is consistently outpacing the capacity of orthopedic surgeons globally. This makes the fair distribution of resources a constant and pressing challenge for our profession. It demands difficult ethical considerations in our daily practice.
So these are often incredibly difficult decisions, made based on immediate medical needs, projected outcomes, the resources available, posing profound ethical dilemmas for everyone involved. But the question is, are these decisions always applied equitably? Hashtag 1.2, unpacking disparities in orthopedic trauma management. Right. While there's extensive discussion and robust research about demographic and socioeconomic factors influencing elective orthopedic procedures, think about joint replacements. For instance, there seems to be a concerning gap in our understanding when it comes to orthopedic trauma surgeries. What does our current insight reveal about disparities in this critical area? And why is this distinction particularly important for trauma?
You've really hit on a crucial distinction there. Unlike elective surgeries, orthopedic trauma involves injuries that demand non-elective, often immediate surgical intervention. Delays in these cases can lead to truly detrimental outcomes for patients.
Often irreversible, I imagine.
Precisely. Frequently irreversible outcomes, from permanent disability to increased pain and functional impairment. And the emerging picture from various studies is quite concerning. It consistently indicates a decreased allocation of surgical resources for individuals identified as Black, those from lower socioeconomic strata, those with lower educational attainment, and those lacking adequate insurance. Now, this isn't about patient preference for delaying surgery. It strongly suggests systemic biases are influencing access to urgent care.
Even when the clinical urgency is high.
Exactly. Even when the clinical urgency is unequivocally high. It forces us to ask some tough questions about fairness in our system.
That's a profound challenge to our professional ideals. It brings us directly to a core concept in bioethics: distributive justice.
Yeah.
What does this principle truly entail in the context of orthopedic trauma, and how does it relate to the broader principles of biomedical ethics that are meant to guide our practice?
Distributive justice refers specifically to the fair and equitable distribution of health resources and benefits within society. It's one of the four key bioethical concepts first articulated, I believe, by Beauchamp and Childress back in 1979. We talk about autonomy, the patient's right to self-determination. Non-maleficence, our moral obligation to do no harm. And beneficence, our moral obligation to act in the patient's best interest. Now, while non-maleficence and beneficence primarily fall upon the individual medical provider, justice, particularly distributive justice, involves a broader task force and systemic considerations. It's bigger than just us. Philosophically, this is rooted in ideas like the egalitarian theory, which posits that everyone should be treated equally regardless of background, and John Rawls's theory of justice, which emphasizes creating a system of fair opportunity. These philosophical underpinnings are central to understanding distributive justice. Our professional mission, as outlined by bodies like the American Academy of Orthopaedic Surgeons, is to provide the highest quality musculoskeletal care for every patient every time. The observed disparities in trauma management directly challenge our ability to uphold this mission. It's not just about what we can do surgically, but what we should do, and how we ensure everyone has an equal chance at receiving that care. Hashtag 1.3. The influence of race and socioeconomic factors on orthopedic trauma care.
Let's delve deeper into the specific factors that contribute to these inequities. Starting with race, how does this complex sociocultural construct and the associated systemic racism truly influence clinical decision-making and access to orthopedic trauma care?
Right. Race, as we now understand it, is primarily a sociocultural concept, not a purely biological one. Yet, systemic racism regrettably contributes to profound problems within healthcare. Its influence is pervasive, ranging from affecting clinical decision-making to maintaining discriminatory barriers. It can even, in some cases, lead to unfair treatment of healthcare professionals from minority backgrounds. The COVID-19 pandemic vividly exposed these healthcare inequities. Indeed, a national U.S. survey from 2017 revealed something quite stark. Approximately 22% of Black adults avoided seeking medical care specifically due to a fear of discrimination.
22%. That's genuinely shocking. It speaks volumes about systemic trust issues, doesn't it?
It does indeed. And it points to how pervasive this problem truly is. When we look at orthopedic trauma specifically, research has consistently highlighted these disparities. For example, a 2011 study observed that Black patients were less likely to be treated with open production internal fixation, or ORIF, for distal radius fractures compared to white patients. The author suggested this discrepancy likely stemmed from implicit beliefs among clinicians that Black patients have a lower risk of osteoporosis, making them perhaps more likely to tolerate non-surgical management.
Even when surgery might have been clinically more appropriate.
Potentially, yes. Similarly, a 2019 study found that rates of surgical fixation for calcaneal fractures were significantly lower among African American and Hispanic patients. And this was even after rigorous accounting for other influencing factors like injury severity or comorbidities. These examples demonstrate how race, as a social construct, along with subtle but pervasive systemic biases, can profoundly affect access to definitive surgical care in trauma settings.
Beyond race, socioeconomic status is such a multifaceted determinant of health. How do things like income, insurance, geographic location, and educational level, how do they individually and collectively exacerbate disparities in orthopedic trauma management? It's a complex web, isn't it?
It truly is a complex, multi-layered determinant. Let's try and unpick each of those. Firstly, income and occupation. Lower incomes and poverty, for instance. Individuals living below the federal poverty level present significant barriers to accessing medical care. That's fairly clear. But research on calcaneal fractures, the 2019 study again, found that median zip code income significantly influenced the type of treatment received. Lower income zip codes were associated with decreased utilization of ORF. This illustrates a profound interplay between a patient's financial status, the surgeon's decision-making process, and, crucially, access to advanced and potentially more effective care. And low income rarely stands alone, does it? It often correlates with lack of robust insurance, food insecurity, living in less safe neighborhoods, creating a compounding effect that deepens health disparities. Secondly, insurance. In countries like the United States, a significant portion of the population lacks health insurance. But even having insurance doesn't guarantee equitable access.
Because of high deductibles or limited networks.
Exactly. High deductibles, prohibitive co-pays, or limited provider networks. Insurance status profoundly impacts access to services and the type of treatment received. A 2019 study on clavicle fractures clearly showed that patients with private insurance had more effective use of surgery compared to those with non-private or no insurance. Uninsured patients, notably, had the lowest odds of undergoing surgery for their fractures.
This strongly suggests that insuring status can implicitly bias surgical allocation, even for urgent traumatic injuries. Our overarching goal as orthopedic surgeons must always be to allocate surgeries based on clinical need, surely not a patient's insurance provider. Thirdly, geographic location. Geographic disparities profoundly affect patient care, particularly for specialized fields like orthopedics. For example, while nearly 20% of the American population resides in rural communities, only about 9% of the physician workforce serve these areas. And this disparity is even more pronounced among specialists, including orthopedic surgeons.
Which naturally limits access to specialized care.
It does. It leads to variations in treatment. The 2011 discal radius fracture study also reported variations in ORAF use across the U.S., with clusters of high use correlating with access to hand specialists. These specialists are often more likely to implement new and, at times, more expensive innovations. We also need to consider the framework of urban bioethics. This helps us understand how density, diversity, and disparity uniquely affect the health of urban populations and the ethical concerns arising within these incredibly complex environments. And finally, education. Variations in educational attainment directly impact health literacy, a patient's ability to understand, navigate, and act on health information. This affects their comprehension of surgical procedures, their capacity to weigh options and risks, and their compliance with crucial preoperative or postoperative protocols. A review in 2015 found that low health literacy in orthopedic and transplant patients was consistently associated with non-adherence to instructions and poor comprehension of surgical procedures. This underscores the urgent need for targeted, accessible educational interventions to empower patients, to help them be active, informed participants in their own care journey.
So if these are the stark realities we face in our day-to-day practice, what's our collective professional responsibility as orthopedic surgeons? What's the takeaway here?
Well, our collective responsibility is multifaceted. It extends far beyond the operating theater. It means understanding that improving healthcare delivery isn't just about honing our vital clinical and technical skills. That's crucial, obviously. But it's also about actively challenging structural racism, confronting our own unconscious biases, and diligently working to dismantle systemic barriers, to ensure all patients receive equitable, high-quality care regardless of their background or circumstances. We must all contribute to creating a system that truly embodies distributive justice and fair access for everyone.
Okay, moving on. For decades, orthopedics has seen the strong and, let's be clear, often incredibly beneficial drive towards specialization, even super specialization. We've seen remarkable advancements and improved surgical outcomes because of it, no doubt. However, the discussion now seems to be shifting, advocating for a return or perhaps an integration of generalist skills. Why is this becoming increasingly vital now? And is it a contradiction to our established highly specialized roles, or is it more complementary?
That's an excellent and timely question. And I would argue it's absolutely not a contradiction, but rather a necessary evolution. A complementarity, as you suggest. Specialization has undeniably propelled surgical outcomes, research, and technical expertise forward. We've all benefited from that precision and depth. However, the current medical literature, including perspectives in papers on generalism and orthopedics, increasingly highlights significant disadvantages to an overly narrow focus. These disadvantages include the fragmentation of knowledge and, crucially, a fragmented approach to patient care, where patients can inadvertently be seen as, well, a collection of isolated parts rather than a whole, complex individual. There's a powerful and frankly quite concerning example often cited which illustrates this point perfectly. A surgeon declining to x-ray a patient's healing femoral fracture because they were only treating a fresh humeral fracture.
Meaning the patient had to come back just for another x-ray.
Exactly. Separate visit, separate imaging. This anecdote, which isn't an isolated incident, I suspect, shows how a hyper-specialist mindset, when taken to an extreme, can inadvertently lead to a less person-centered approach, and even the medicalization of complex problems, rather than truly treating the patient holistically.
That's a vivid illustration of the potential pitfalls. It suggests that while depth of expertise is absolutely crucial, a certain breadth of understanding is becoming equally, if not more, important. Are there broader frameworks that underpin this shift towards generalism? It feels like a wider trend.
Precisely. This isn't just an anecdotal observation within orthopedics. It's a recognition across the entire medical profession. Major frameworks for change, such as the Shape of Training Review in 2013 and the Future Doctor Report in 2020 in the UK, both unequivocally recognize the crucial need for greater generalist skills. Even within specialty training, The goal is to equip future doctors with a nuanced understanding of population health, a broader perspective on the social determinants of health, and system-wide knowledge, not just narrow technical expertise. Programs like the Enhancing Generalist Skills, the Enhance Initiative, have been specifically developed to incorporate this into medical and multi-professional practice, underscoring its institutional importance.
So when we talk about generalism for an orthopedic surgeon, what does that practically entail? What does it look like on the ground? How does it integrate with, rather than replace, our specialist expertise in musculoskeletal care?
Right. Generalism, as defined by the Royal Australasian College of Surgeons, is a philosophy of care distinguished by a commitment to the breadth of practice within each discipline and collaboration with the larger healthcare team to respond to patient and community needs. It's vital to understand that this isn't about becoming a GP or a family doctor. It's about cultivating a holistic professional approach within our orthopedic specialty. This involves understanding the wider healthcare system we operate within, recognizing the interdependency of professional skills across various medical disciplines, and possessing a broad range of clinical and behavioral skills applicable across different healthcare environments. It's about looking beyond the immediate orthopedic issue to the whole patient, their multiple health conditions, their psychosocial context, their social environment. It's about maintaining a basic but current level of general medical knowledge and skills, enough to effectively supervise multidisciplinary teams, manage complex handovers, review entire medication lists, make appropriate referrals to other specialists, and minimize unnecessary investigations.
Ultimately, it's about person-centered care. Ensuring the patient's overall well-being is at the forefront. Hashtag tag 2.2, navigating complex multimorbidity in orthopedic practice.
And a key, perhaps the primary driver for this renewed emphasis on general skills must be the pervasive and growing challenge of managing patients with complex multimorbidity. How prevalent is this in our patient population now? And what unique difficulties does it present for us as orthopedic surgeons, traditionally focused on a specific musculoskeletal condition?
Multimorbidity, commonly defined as having two or more chronic medical conditions, is, quite simply, increasingly the norm rather than the exception in modern healthcare. The data is quite striking. Large studies, like one from Scotland, reported that around 65% of those over 65 and nearly 82% of those aged 85 or older had two or more chronic conditions. And importantly, in absolute terms, multimorbidity is also prevalent in those under 65 and is significantly more common in socioeconomically deprived areas. So it affects a broad spectrum. This has a profound impact on patients' quality of life, their functional capacity, almost inevitably leads to polypharmacy, the use of multiple medications, and imposes a substantial treatment burden.
Including psychological distress, I imagine.
Absolutely. Significant psychological distress often accompanies it. As orthopedic surgeons, we simply cannot treat an affected limb or joint in isolation anymore. We must consider the entire health profile.
That prevalence is really quite striking. Could you paint a picture for us, perhaps using that hypothetical case you mentioned, of the sheer complexity this creates for a single patient navigating the healthcare system?
Certainly. A striking hypothetical case described in the BMJ involved a 78-year-old woman. She had a history of myocardial infarction, type 2 diabetes, osteoarthritis, COPD, and depression. Now, she would typically be prescribed a minimum of 11 different drugs, with the potential for 10 others depending on her symptoms.
11 drugs minimum.
Minimum. She'd also be advised to engage in at least 9 distinct lifestyle modifications. On top of any unplanned appointments, she'd require 8-10 annual routine primary care appointments for her physical conditions, plus many more for psychosocial interventions and smoking cessation support. This example clearly highlights the overwhelming complexity and the enormous treatment burden placed on such a patient. It's like a full-time job just managing their health. And it really underscores why a narrow specialist view just isn't sufficient anymore.
In such complex scenarios where patients are juggling so many conditions, how can we ensure truly person-centered orthopedic care? Especially when traditional disease-specific guidelines often fall short. Our guidelines are often designed for single issues, aren't they?
This is precisely where those generalist skills become absolutely indispensable. Traditional single-disease clinical guidelines are often inadequate because the randomized controlled trials, upon which these guidelines are typically based, routinely exclude older people and those with multiple chronic conditions.
The very people we're talking about.
Exactly, the very people we often treat. This means that while individual recommendations might be evidence-based in isolation, some can be irrational, contradictory, or even harmful for a multimorbid patient. It necessitates a reliance on robust clinical judgment. Sometimes accepting that stringent disease-specific targets might not actually be beneficial for the patient's overall well-being and quality of life. Furthermore, prioritizing conditions like depression, which significantly impacts a patient's ability to manage their other chronic conditions and adhere to treatment plans, can be absolutely crucial for overall success. You have to see the whole picture.
So we need adaptable, evidence-based strategies to manage this complexity effectively. What does the evidence suggest are the most effective approaches for improving care for patients with multimorbidity in our field? What can we practically do?
Well, there are several evidence-based strategies that have proven effective, and orthopedics can certainly learn a great deal from them. Firstly, a crucial shift involves focusing on function, not just disease. This is key. A Cochrane systematic review of community-based interventions highlighted promising results from interventions directed at generic functional difficulties, rather than solely at individual diseases. For instance, one randomized controlled trial involving occupational therapists and physiotherapists significantly improved health outcomes, including a statistically significant reduction in mortality over 2 years for older multimorbid adults. This strongly underscores the importance of a multidisciplinary and function-oriented approach in orthopedics. Improving mobility, independence, and overall quality of life can be as important, if not more so, than simply fixing a bone or joint in isolation. Secondly, optimizing medicines management is paramount. Given the prevalence of polypharmacy, regular proactive drug reviews are essential. This includes deprescribing, a systematic process of stopping or reducing drugs that are no longer indicated, lack prognostic benefit, or cause unacceptable side effects. We have validated specific tools to aid this. The SWPP criteria screening tool of older persons' potentially inappropriate prescriptions with 65 indicators for those 65 or older, and the START criteria screening tool to alert doctors to right treatment, which lists 22 evidence-based prescriptions for long-term conditions. And for younger patients, the PROMPT criteria prescribing optimally in middle-aged people's treatments are actively being developed. So this is a continuously evolving field. Thirdly, enhancing organization and continuity of care is vital. Patients with complex multimorbidity benefit immensely from consistent continuity of care. Practices should actively identify these patients and ensure they have a named doctor or lead clinician responsible for overseeing their complex needs. Practical steps could involve adopting a policy of routine extended consultations for complex patients or scheduling specific extended consultations to allow protected time for a truly comprehensive review. Utilizing practice nurses or other multidisciplinary team members for initial assessments and monitoring before doctor appointments can also significantly maximize consultation efficiency. It ensures that the valuable time with the orthopedic surgeon is used for the most critical decisions and shared planning. And finally, promoting patient-centered shared decision-making is absolutely non-negotiable. Eliciting what matters most to the patient at the outset of a consultation simply by asking, "What is bothering you most today?" or "What would you like to focus on in our time together?" is key to prioritizing care that genuinely impacts their well-being. Decision-making models, like the Choice Talk, Option Talk, Decision Talk framework, and the Ariadne principles, provide structured frameworks. They support clinicians in implementing shared decision-making, focusing on realistic treatment goals and highly individualized management, rather than a rigid, disease-specific approach that might not align with the patient's own priorities.
It's clear, then, that this generalist mindset positions the orthopedic surgeon not just as a highly skilled technician, but as a crucial leader within a broader integrated team. Advocating for the patient's entire well-being, this really requires a systemic view.
Absolutely. This holistic responsibility extends beyond the individual patient. It encompasses an active role in shaping the systems within which we operate to better serve these increasingly complex patient populations. We are, in effect, system architects as well as surgeons.
Right, building on our discussion of multidisciplinary care for multimorbidity, which clearly highlights the need for collaboration, let's turn our attention to the internal dynamics of orthopedic teams. What constitutes effective teamwork in our fast-paced environments, and what are the prevalent challenges that can hinder its success and, crucially, patient safety?
Teamwork is defined as an adaptive, dynamic, and episodic process. It encompasses the thoughts, feelings, and behaviors of team members interacting towards a common goal. It's far more nuanced than just individuals performing tasks. It's intrinsically about how those tasks are performed collaboratively and interactively. It typically involves 6 core processes: coaching, conflict resolution, communication, cooperation, cognition, and coordination. And research consistently links poor teamwork to adverse events in healthcare. That's well established. Specifically within orthopedic departments, studies have attributed a significant proportion of adverse events to poor situational awareness,
flawed decision-making, ineffective leadership, and communication breakdowns, particularly in the critical peri- and post-operative phases of care where timely, accurate information exchange is absolutely paramount.
The material we've looked at highlights a very interesting design thinking approach to uncover specific opportunities for improving teamwork. Could you outline some of the key themes identified through this human-centered approach and perhaps share their practical intervention suggestions?
Indeed. A design thinking approach, being human-centered and iterative, proved incredibly effective in pinpointing these issues and developing potential solutions. We can group the findings into several key themes with practical, actionable suggestions. The first theme revolved around the influence of attitude and environment on communication between nurses and junior doctors. We observed fragmented communication and significant cognitive overload during daily ward rounds. This was often due to multitasking nurses simultaneously checking paper notes and digital reports, while doctors were busy seeking x-rays. And even the physical setup, with team members sometimes sitting with their backs to each other, creating barriers to natural interaction.
Not ideal for collaboration.
Not at all. Nurses frequently expressed that patient feelings or holistic perspectives were overlooked due to time constraints. One nurse reportedly remarked, "They always ask about the pain, but not how the patient feels." Hierarchy also played a role in larger multidisciplinary rounds, making it difficult for some, particularly less experienced staff, to contribute effectively. For intervention, we suggest designing a unique Shared Electronic Health Record, EHR, screen specifically for daily rounds. This screen could structure information with visual cues to reduce multitasking and cognitive load. Optimizing room layout to facilitate face-to-face interaction is also crucial. Simple but effective. Furthermore, promoting structured communication frameworks like SBR situation, background assessment, recommendation can guide clear, concise communication and foster clinical thinking, particularly for less experienced staff, thereby building their confidence and reducing communication errors. The second theme identified was the crucial need for mutual understanding to improve collaboration. Smooth, effective collaboration is highly dependent on team members understanding each other's needs, motivations, and goals. This is often easier within the same profession, but becomes profoundly challenging across multidisciplinary teams.
Where different professional cultures might clash slightly.
It's exactly where profession-specific cultures and even languages can inadvertently hinder common understanding. An example cited was the initial skepticism among nurses regarding the rapid recovery program aimed at reducing length of hospital stay. This skepticism persisted until the new methodology proved demonstrably successful. Building personal bonds and observing colleagues' working styles were consistently identified as crucial for fostering trust and breaking down those professional silos. Our intervention suggestions here include implementing shadowing activities. For example, junior doctors could spend a day with nurses, or nurses with physiotherapists, or vice versa. These activities should be guided by specific objectives and questions to stimulate empathy and reflection on pre-existing frictions. This approach fosters shared knowledge, a deeper appreciation for different roles, and ultimately improves trust and collaboration across the team. A third significant theme was connecting the patient with the professional team. Patients are often inadvertently viewed as the subjects of care rather than active team members. Despite their significant role in dictating care standards and influencing teamwork through their level of engagement and understanding, and different professionals don't always adapt consistently to varying patient profiles and their unique communication needs or health literacy levels. Intervention suggestions for this theme include designing tools that explicitly accommodate individual patient profiles and communication strategies. This means providing patients with clear, layman explanations of treatments and recovery times, perhaps using graphical visualizations to empower them. Such tools can be used both to prepare patients for consultations and to facilitate communication during the consultation itself, ensuring consistent information delivery and managing patient expectations effectively across their entire journey. And finally, the fourth theme was the impact of organizational changes on team dynamics and fostering learning. Organizational changes, especially the frequent influx of new colleagues, for instance, new nurses rotating through, junior doctors changing posts, can lead to decreased performance and errors due to a lack of experience or system-specific knowledge.
Which inevitably impacts other team members.
Naturally, it affects the whole team's rhythm. Existing briefing activities often lack a clear learning orientation, with some surgeons reportedly viewing day evaluations as largely ineffective or perfunctory, just ticking a box. For this, we suggest transforming traditional briefing and debriefing sessions into learning-oriented huddles. This could involve nurses collecting and sharing learned events, for example, non-standard cases, unexpected complications, and how they were solved on visible boards to facilitate knowledge dissemination across shifts. The overarching goal is to create a positive learning environment where psychological safety is prioritized, actively encouraging open discussion, reflection, and continuous improvement without fear of judgment.
Okay, so teamwork is crucial internally. But our profession's impact isn't limited to human interactions and patient care. It extends significantly to the environment. The healthcare sector, and particularly the operating theater, contributes substantially to global carbon emissions. What are the key areas of concern here? And what proactive steps are being taken within surgery to address this critical issue?
You've highlighted an increasingly urgent concern that directly impacts public health, actually. Healthcare is a substantial contributor to climate change. It accounts for approximately 5% of global carbon emissions.
5% globally. That's significant.
It is, and around 8.5% of U.S. greenhouse gas emissions. Within healthcare, the operating theater is a major hotspot. This is due to its significant waste generation, high energy consumption, and use of specific anesthetic gases. Recognizing this, leading medical societies globally, SAGES in the U.S., EAEs in Europe, have already formed dedicated task forces. Their mission is to promote education, mitigation strategies, and innovation towards more sustainable surgical practices. It's a movement orthopedics must fully embrace as a core responsibility.
For orthopedic surgeons and their teams, where can they make the most tangible impact in reducing the environmental footprint of their practice? Why should we focus our efforts?
There are several critical areas where orthopedic surgeons and their teams can make a real and measurable difference. Firstly, waste reduction strategies. Surgical waste is a primary contributor to the carbon footprint. Initiatives should focus on the classic 3 Rs, refusing unnecessary items, reducing consumption, and improving recycling. Studies consistently show that reusable equipment generally has a lower environmental impact than disposables. This has been robustly demonstrated through life cycle assessments, or LCAs. A significant proportion of surgical waste figures like 75% of equipment-related consumables in common procedures like appendectomies have been cited, can often be avoided through careful planning and lean practices. This leads to both cost savings and reduced greenhouse gas emissions. Simple changes in how surgical trays are configured and used can have a profound effect. Secondly, anesthetic gases. Certain anesthetic gases, particularly deflurane, have a very high global warming potential, thousands of times that of CO2.
Thousands, wow.
Yes, it's staggering. Substituting these with alternatives like sevoflurane, increasing the use of regional blocks local anesthetics, or favoring total intravenous anesthesia, TIVA, can yield substantial environmental and financial benefits. It significantly reduces our carbon output. Close collaboration with our anesthesia colleagues is absolutely vital here to drive this change. Thirdly, surgical approach considerations. The type of surgical approach chosen can influence the environmental footprint. Now, while minimally invasive procedures using non-energized dissection technique often reduce CO2 emissions compared to open surgery, it's worth noting that LCA analyses of robotic approaches sometimes reveal higher energy usage and increased solid waste production. This isn't to say one is always better environmentally, but it highlights the need for careful evidence-based consideration of environmental impact when choosing between different surgical techniques. It's another factor to weigh up. Fourthly, reducing surgical complications. This is perhaps less obvious but very important. Unexpected complications, like a surgical site infection or an unplanned return to theater, can substantially increase a patient's carbon footprint. This occurs through extended hospital stays, additional procedures, increased CO2 equivalent emissions from equipment and energy use, greater water consumption, and significantly more waste generation. Therefore, proactive measures to reduce surgical complications have a powerful dual benefit: improved patient outcomes and a lower environmental impact. Fifthly, energy and water conservation. Simple, low-cost interventions can significantly reduce energy and water consumption in the operating theater and the wider hospital. Examples include installing heat recovery systems, adopting judicious taps-on, taps-off techniques during surgical scrubbing, simple habits, or utilizing alcohol-based scrub alternatives which use considerably less water. These seemingly small changes, when scaled across an entire hospital system, add up to significant savings and reductions in environmental impact. And finally, educational and organizational initiatives. Implementing things like sustainability report cards to provide monthly feedback on the utilization and costs of disposable versus reusable supplies can effectively drive behavioral change across surgical teams. Education on proper waste sorting, Developing robust change management programs focused on surgical sustainability competencies, and even establishing fellowships in green surgical practices are all critical steps. Educating staff on the mitigation of anesthetic gas use, particularly dyslorane, has also been found to be significantly impactful in driving immediate change. It empowers people to act.
So, the concept of a green operating room isn't merely about environmentalism, is it? It seems deeply integrated with responsible, ethical, and effective medical practice, improving both patient care and the health of the planet simultaneously. It feels like a fundamental part of our oath, actually.
Absolutely.
Yeah.
Beyond reducing costs and carbon emissions, embracing sustainable practices promotes social equity. We know pollution disproportionately affects lower-income communities and minority populations globally. It fundamentally aligns with healthcare's broader mission of promoting health and well-being. Orthopedic surgeons can actively participate in multidisciplinary green OR teams and advocate for the 10R model of a circular economy: refuse, reduce, reuse, recycle, recover, repair, and so on, to minimize waste and enhance environmental performance, all while always maintaining high-quality patient care. It's about being responsible stewards of both human health and planetary health. They are inextricably linked.
Our entire deep dive today truly underscores a significant evolution in the role of the orthopedic surgeon. It's clearly extending far beyond the traditional image of technical expertise in the operating theater, which is perhaps what many of us initially envisioned when we entered the field. What does this modern orthopedic surgeon truly embody now?
Well, the modern orthopedic surgeon is increasingly a multifaceted leader, embodying not just surgical skill, but also vision, remarkable adaptability, and a truly holistic understanding of patient care. This redefined role demands comprehensive patient evaluations that consider not only medical history and functional abilities, but also those crucial psychosocial aspects we discussed. Things like mental health, social support, financial stability, which profoundly impact recovery and long-term well-being. It encompasses meticulous preoperative planning, precise surgical execution, and diligent oversight of rehabilitation, positioning the surgeon as a clinical strategist integrated across the patient's entire recovery framework. We are no longer just fixing bones or joints. We are orchestrating a complex journey back to full function, addressing the whole person, not just the orthopedic injury.
Orthopedics has always been a field that welcomes change and thrives on innovation. It seems to be in our DNA. How are surgeons actively at the forefront of integrating new technologies? And what is their indispensable role in shaping future research and training the next generation of practitioners?
Orthopedic surgeons are certainly not passive observers of technological advancement. We are hands-on drivers of innovation. We are actively implementing and rigorously evaluating technologies such as robotic-assisted procedures, augmented reality in surgical planning and rehabilitation, AI-based imaging for diagnostics and predictive analytics, and custom 3D printed implants for highly tailored solutions. Our role involves rigorous testing, critical questioning of limitations, and ensuring that any innovation reaching a patient is robustly backed by evidence and proven results, not merely by hype or novelty. We are committed to translating promising technology into tangible, safe, and effective patient benefit. It's about responsible adoption. In terms of research, the focus has broadened significantly, moving beyond purely technical efficacy. We're evolving past questions like, did the surgery work, to more profound inquiries such as, was it truly worth it for the patient? Did the patient genuinely feel the difference in their quality of life, their independence, their ability to participate in society?
And was the care fair?
It's exactly. Was the care fair and equitably distributed? And crucially, could we do it better, more efficiently, more sustainably? This expanded lens brings greater meaning and relevance to our published research, allowing it to have a more profound and widespread impact on both clinical practice and population health. We're actively working to close that gap between research findings and real-life outcomes. And for education, committed mentorship is absolutely vital. The aim is not just to teach technical skills, how to drill a screw or align a joint, important as they are. It's also to impart critical judgment, profound humility in the face of uncertainty, and the grit required to navigate complex cases and unexpected challenges. Now, while new tools like surgical simulators and structured skills labs are transforming training methodologies, offering invaluable opportunities for deliberate practice in a safe environment, the human element remains paramount. That guidance, correction, active listening, that personal connection, that mentorship is what truly shapes the next generation's perspective, preparing them not just as highly skilled technicians, but as thoughtful, adaptable, and ethically grounded professionals.
The issue of distributive justice and healthcare disparities has been a central theme today. How are orthopedic surgeons stepping up to address these inequities? And how are they influencing the wider healthcare system through administrative and policy involvement?
Orthopedic surgeons are increasingly becoming pivotal in advocating for social justice within healthcare. It's a growing recognition of our role. They are at the forefront of global health initiatives, for example, helping to build surgical capacity in underserved regions worldwide and promoting cost-effective technologies that can bring essential, life-changing care to more people. Domestically, their push for fair access to orthopedic care, particularly for minority and underserved communities, highlights their profound commitment as social stewards, and their invaluable hands-on clinical experience is increasingly leveraged in administrative and policy involvement.
Bringing that frontline perspective.
Precisely. Shaping strategic decisions, modifying surgical schedules for greater efficiency and equity, arranging community health initiatives, their active participation in hospital governance, quality assurance committees, and policy creation bridges that real-world expertise with comprehensive institutional strategies, ensuring that the realities of patient care directly inform the systems that govern it.
Finally, how does this expanding and increasingly holistic role integrate with the pervasive shift towards value-based care models in healthcare? That term is everywhere now.
Value-based care fundamentally prioritizes patient outcomes and cost-effectiveness, moving away from purely volume-based systems. Orthopedic surgeons are absolutely central to this paradigm. Our focus must extend beyond the immediate technical success of surgical procedures to the long-term patient functionality, their satisfaction with life, and their overall quality of life. That's the value. This shift necessitates aligning surgical goals closely with the unique needs and priorities of individual patients and the broader performance metrics of the healthcare system. It's about embodying the philosophy, as Sir William Osler famously stated, that the good physician treats the disease. The great physician treats the patient who has the disease. We are striving for that great physician standard, ensuring our interventions genuinely add lasting value to our patients' lives and to the health system as a whole, making every intervention count in the most meaningful way possible. #outro.
Professor Imam, we've truly embarked on a comprehensive deep dive today. From the ethical foundations of resource distribution and the complexities of multimorbidity to the practicalities of optimizing teamwork and embracing environmental sustainability, and the profound evolution of the orthopedic surgeon's role itself, it's clear that orthopedics is a field constantly challenging its practitioners to grow far beyond traditional boundaries.
Absolutely. The future of orthopedics demands a mindset that looks beyond the immediate surgical site to the whole patient, their intricate health profile, and their societal and environmental context. It requires a commitment to leadership, remarkable adaptability, and a relentless pursuit of equity and value in all that we do. It's about cultivating those crucial generalist skills alongside our specialist expertise to navigate an increasingly complex world and truly serve our patients in the best possible way.
It certainly is an exciting, albeit demanding, time to be an orthopedic professional. We truly encourage you, our listeners, to reflect on how these insights resonate with your own practice and how you might contribute to shaping a more holistic, equitable, and sustainable future for our specialty.
We sincerely hope this deep dive has offered some valuable perspectives for you to consider as you navigate the ever-changing healthcare landscape.
If you found this discussion insightful and valuable, please do take a moment to rate and share this deep dive with your colleagues. Your support truly helps us continue these important conversations. And finally, a thought to leave you with. As you consider your next patient, what one generalist skill could you consciously cultivate this week that would most profoundly impact their overall well-being beyond the immediate orthopedic concern?